Welcome to ADAA's Professional Education webinar, examining the relationship between emotion regulation, sleep quality, and anxiety disorder diagnosis, presented by Dr. Kristin Szuhany. Dr. Szuhany is an assistant professor at NYU Grossman School of Medicine and NYU Langone Health, who has dedicated her career to clinical and translational research in anxiety disorders with the Anxiety, Stress, and Prolonged Grief program, where she also serves as the assistant director. She also has a clinical practice at NYU, where she implements her extensive experience with evidence-based assessment and treatments for adults with anxiety disorders, PTSD, grief and depression, including cognitive behavioral therapy and behavioral activation. Dr. Szuhany is the 2024 Donald F. Klein Early Career Investigator Awardee. ADAA offers this annual award to an early career investigator for best original research. Welcome, Dr. Szuhany.
Thank you so much. I'm very excited to be here today to speak at this webinar. I am Kristin Szuhany, as you heard. I'm an assistant professor at NYU Grossman School of Medicine. And as part of the 2024 Donald F. Klein Early Career Investigator Award, I'll be presenting to you the project that I submitted for this award entitled Examining the Relationship Between Emotion Regulation, Sleep Quality, and Anxiety Disorder Diagnosis. My disclosures include grant support from NIMH, K23 Career Investigator Award, Brain and Behavior Research Foundation Young Investigator Award, and I serve as an associate editor for the journal Mental Health and Physical Activity. So I want to start, and I will also be ending today's presentation with some recognitions and thank yous. First and foremost, I have to thank the co-authors of this paper on which this presentation is built today. If I pique your interest with this talk today, you can find this paper published in ADAA's Journal of Mood and Anxiety Disorders. But of course, want to thank all the co-authors for all their hard work on this paper, without which this presentation would not be able to happen. I also want to thank my mentors, past and present, only some of whom are represented here. All of my mentors and collaborators over the years have been essential in my journey to get to this point so far as an early career investigator. And I really appreciate all the knowledge and support they've imparted, which is something I'll carry throughout my career and continue to go back to them throughout my career as well. And of course, I want to also thank ADAA and the Donald F. Klein Early Career Investigator Award. This award supported my attendance at the recent ADAA conference. It supported my submission of this paper for consideration at the Journal of Mood and Anxiety Disorders, this webinar that I'm hosting, giving you to you today, as well as, most importantly, the ability to connect with amazing researchers and clinicians represented at ADAA. So today I will walk through a few different things. First, I want to tell you a little bit about myself and my path and research and kind of what got me here today. And then I'll go more specifically into this project, a little bit about the background, as well as more specifically the methods and results from the project, and then save some time for a few final words about my experience as this year's ADAA's Donald F. Klein Early Career Investigator Awardee. So to start, a little bit about myself, my path and my research. My path in psychology began as an undergraduate at the University of Pennsylvania during my sophomore year when I started my first volunteer research experience. I started in the lab of Dr. Ayelet Ruscio, and this is where I first got interested in clinical diagnoses and in particularly anxiety disorders, because in this lab we were aiming to understand differences between high warriors with and without generalized anxiety disorder. And really this started to pique my interest, one, in just clinical research in psychology, as well as different specific characteristics that differentiated normative processes from those that defined anxiety disorders, something that you'll see in my presentation of the specific project that I'm talking about today. At Penn, I also worked in the lab of Dr. Angela Duckworth, where I did my honors thesis, studying processes that promoted motivation and well-being, such as grit, which is really hallmark of another line of my research in exercise interventions for mood and anxiety disorders. After I graduated, I completed a post-baccalaureate fellowship at the National Institute of Mental Health. And here I worked in the lab of Dr. Daniel Pine, And here I continued my work and interest in anxiety populations and got to learn a little bit more about differential fear reactivity among those with and without anxiety disorders. And this really sparked my interest in understanding physiological, cognitive, and emotional factors that are involved in the etiology and maintenance of anxiety disorders. And during this time period is when I attended my first ADAA conference in 2010 in Baltimore. So the first of many ADAA conferences to come. Next, I moved to graduate school, a PhD program in clinical psychology at Boston University under the mentorship of Dr. Michael Otto. And here again, continued working with clinical populations, particularly clinical anxiety and depression populations. But I got my first intrigue into novel intervention strategies and different novel augmentation strategies to evidence-based interventions. And during my first year, my first time working with patients as part of a research study that was studying D-cycloserine as an augmentation strategy to brief cognitive behavioral therapy for panic disorder. So this kind of sparked my interest in these novel augmentation strategies, which then led me to the beginning of my beloved line of research in exercise interventions, starting off with an F31 supported by NIMH, which supported my dissertation, investigating exercise as an augmentation strategy to evidence-based brief behavioral activation treatment for major depressive disorder. Then I moved to my clinical internship year at Montefiore Medical Center under the guidance of Dr. Simon Rago. Here, of course, much of my time was spent doing clinical work, but I also was still interested in carrying my interest in intervention research. And I created a group to promote exercise for mood for individuals with both anxiety and depressive symptoms, many of whom had significant medical comorbidities as well. After this year, I moved to my postdoctoral fellowship at NYU, which, as you can see, is still where I am today. So this started my pathway and my continuation at NYU. This postdoctoral fellowship was under the direction of Dr. Naomi Simon, who I still work with closely today, and again, kept my interest in anxiety disorders, but also to look at some transdiagnostic processes that underlie anxiety disorders, such as sleep, and other novel intervention strategies like mindfulness-based stress reduction. And during this time frame in my postdoctoral fellowship is also when I participated in ADAA's Career Development Leadership Program, which is a great experience as well. And I'll talk about this a little bit at the end of my talk as well. In 2019, I transitioned to faculty here at NYU. And in 2021, I was awarded a K23 Career Development Award. And this was to study a novel exercise titration paradigm to improve anxiety sensitivity and exercise engagement in individuals with anxiety disorders and high anxiety sensitivity. And in 2022, I was awarded a Brain and Behavior Research Foundation Award to investigate this was for included my exercise, brought it up to NYU. And then my Brain and Behavior Young Investigator Award brought in my interest in fear extinction learning and consolidation all the way back from my time at NIMH to better understand how exercise might augment as a new strategy the consolidation of fear extinction learning in individuals with anxiety disorders. And ultimately, this again brings in some of that novel augmentation strategies from my time at Boston University to understand how to improve efficiency of exposure-based interventions. And what do I hope out of the future? Well, I hope that it holds ongoing investigations of some of these different things that I've learned throughout the years, including exercise interventions and as they apply to other populations, such as enhancing exercise engagement to promote healthy aging in individuals with risk factors for Alzheimer's disease, such as depressive symptoms and low physical activity. So I walked you through my time in psychology. And now what does this mean and how have I put this all together to understand my overarching research? So overarching my research aims to understand novel intervention strategies, and particularly exercise as a standalone and also augmentation strategy to other evidence-based interventions for individuals with mental health conditions such as anxiety disorders and depression, but also to extend to other avenues such as promoting healthy aging and preventing Alzheimer's disease and other dementias. while also understanding the transdiagnostic mechanisms of action, such as sleep, emotion regulation, and important biomarkers, all in the service ultimately of promoting physical, mental, and brain health. In today's talk, we're really going to focus on is this piece here. So anxiety disorders, and particularly the transdiagnostic processes that might differentiate anxiety disorders from healthy controls, including sleep as well as emotion regulation. And as you can see, this has been a theme somewhat throughout my entire research career. So let's dive into the presentation at hand. And first, I want to start off with a little bit of the background between these three constructs of interest: anxiety, sleep, and emotion regulation. So I'll start off with highlighting anxiety disorders and sleep disturbance, which, as we know, are both highly prevalent. About a third of people will meet diagnostic criteria for anxiety disorders at some point in their lifetime. And about a third of people report that they don't get enough sleep. Now, not getting enough sleep isn't the same as clinically defined insomnia, which clinically defined insomnia is difficulty either initiating, maintaining sleep, early morning awakening, or poor sleep quality reported for at least 3 days per week for at least 3 months. And what we know is that insomnia frequently co-occurs with anxiety, with estimates of about 25 to 45% of individuals with anxiety disorders reporting co-occurring insomnia. And that co-occurring insomnia can cause additional impairment in functioning. And insomnia in general can predict future anxiety disorder onset. So this really means that that relationship between anxiety and insomnia is likely bidirectional, by which those who have insomnia might be vulnerable to develop future anxiety disorders, and those who have anxiety disorders are likely to report some sort of sleep problems like insomnia. There are also different facets of sleep disturbance that kind of comprise insomnia, and many of these facets are disturbed in individuals who have anxiety disorders as compared to healthy controls. Some of those facets that have been identified include sleep quality, so poor subjective sleep quality throughout the night, sometimes even measured objectively with polysomnography. Shorter total sleep duration, so total sleep time is less than those healthy controls. Poor sleep continuity, so waking up a lot in the middle of the night and not being able to go back to sleep. Poor sleep efficiency, so of the total amount of time spent in bed, less of that time is spent sleeping. Longer sleep onset latency, so taking a longer time to fall asleep at the beginning of the night. And this can be due to things like planning a lot excessively for the next day or worrying about things. And then daytime dysfunction due to poor sleep. So this can be having performance issues at work, not engaging socially because of fatigue or poor sleep. Sleep is one transdiagnostic process that can be disrupted in people with anxiety disorders, and poor sleep can leave people vulnerable to emotion dysregulation, which is another facet that can be disturbed in individuals with anxiety disorders. Emotion regulation has many definitions, but the one that I'll use today is an individual's ability to influence the quality, duration, and intensity of both positive and negative emotions, and an individual's ability to control, express, and experience their emotions. And one common theoretical model of emotion regulation is that of Gratz and Romer, who suggests 6 distinct dimensions of emotion regulation. And those include non-acceptance of emotional responses, so feeling upset or ashamed for experiencing an emotion, difficulties engaging in goal-directed behavior, especially when experiencing a strong emotion, limited access to emotion regulation strategies such as cognitive reappraisal, impulse control difficulties, especially when experiencing negative emotions, lack of emotional clarity, so confusion about how one is feeling, and lack of emotional awareness. And studies have found that some of these particular dimensions more than others seem to be impaired in people with anxiety disorders, such as those with generalized anxiety disorder or social anxiety disorder, compared to healthy controls. And these include in particular dimensions such as accepting negative emotions, describing emotions, and implementing emotion regulation strategies. Surprisingly, very few studies have examined the interconnection among all these three constructs of sleep disturbance, emotion regulation, and anxiety. Some that have, for example, have found that non-acceptance dimension of emotion regulation has been associated with poorer sleep, particularly in individuals with more severe anxiety symptom profiles. And in another study among generalized anxiety disorder patients versus healthy controls, sleep outcomes were fully mediated by emotion regulation, meaning that those troubles in emotion regulation really predicted those sleep problems in the GAD group in particular. So this led us to some identifying a research gap here in our study aims. And really here, we're seeing a lack of understanding about how all these three things interconnect with each other, and particularly the multidimensional constructs of sleep disturbance, which can include many facets, as well as emotion regulation, which can include many facets, and how these facets in particular interconnect with anxiety diagnosis. And the point of our study was to examine if we could classify current anxiety disorder diagnosis based on these different dimensions of emotion regulation and sleep disturbance using a novel machine learning approach in the spirit of identifying potential primary intervention targets, not just emotion regulation or sleep disturbance as a whole, but more fine-tuned targets based on these facets of disturbance. And we hypothesized, aligned with some previous research, that the deficits in emotion regulation would really show up in terms of lack of emotional clarity, lack of emotional acceptance, and limited access to emotion regulation strategies for those with an anxiety disorder diagnosis versus healthy controls. And we hypothesized that the sleep disturbance would particularly show up in terms of poor reported sleep quality and lower amounts of sleep duration. So let's get into the specific study methods and the results. In terms of the study participants, all these participants completed a set of questionnaires at a single time point as part of an ancillary questionnaire-based protocol prior to participating in other research studies. This was conducted at Massachusetts General Hospital from 2008 to 2016. And as you can see here, we have a total sample of around 346 people, where 257 have anxiety disorders, social anxiety disorder, and generalized anxiety disorder as primary diagnoses, and 89 healthy controls. All of the clinical diagnoses were made by structured diagnostic interviews by trained raters of at least master's level. The healthy control participants had no DSM diagnosis within the past 6 months. And all of the eligible participants were required to be adults, at least over the age of 18. They were excluded if they had severe unstable medical illness, alcohol or substance abuse within the past 6 months, history of schizophrenia, psychotic disorders, or bipolar disorder, or if they were at serious acute suicidal risk. And as you can see with this sample, overall, the sample is relatively young, primarily female, as we see in many anxiety disorder studies, primarily white and highly educated as well. So the measures of interest for this particular study were the Pittsburgh Sleep Quality Index, or the PSQI, which is a 24-item self-report of sleep quality in the past month. And this particular measure includes validated subscales, 7 of them in particular that we see listed here: sleep quality, just the subjective rating of how well a person slept; sleep latency, so how long it took to fall asleep; sleep duration, the total time spent sleeping; sleep efficiency, so the amount that they were sleeping over the amount of time that they spent in bed; general sleep disturbance, as well as use of sleep medication to fall asleep; and then daytime dysfunction due to poor sleep. The other measure of interest here was the self-reported difficulties in emotion regulation scale, or the DIRS, which is the short form 36-item scale derived from the clinical model of emotion regulation. And this includes 6 validated subscales: non-acceptance, which measures the individual's lack of acceptance of their negative emotions; the goals subscale, which assesses the ability to direct behavior towards accomplishing goals when experiencing difficult emotions; impulse, which assesses the ability to suppress impulsive behavior in the face of negative emotions; awareness, which measures the awareness and insight into an individual's emotional state; clarity, which assesses the ability to understand emotions; and lastly, strategies, which measures the ability to engage in appropriate strategies to effectively moderate emotional responses. And for both of these scales, higher scores on these scales indicate higher levels of impairment. Our data analytic approach included using a specific machine learning technique called a conditional inference tree. And conditional inference trees are a type of decision tree that recursively partition or split an outcome variable. In this case, our outcome variable was whether they met an anxiety disorder diagnosis or were a healthy control. And the split is based on the strength of association with certain predictors. Here, our covariates or predictors of interest were the emotion regulation or DERS subscales, those 6 subscales, the PSQI or sleep subscales, those 7 subscale scores, and demographic factors. And this split is measured with significant p-values using a permutation test. So all the splits, we constrained the hyperparameters to be a p of less than 0.01 to be conservative, and also used a Bonferroni correction for multiple comparisons. We also constrained the final nodes or the terminal nodes, kind of the last part of our tree, to have a minimum of 30 data points so that there was an interpretable model that came up with using this tree. We also used a 10-fold cross-validation process. So we took 20% of our sample to start and did 10-fold cross-validation of an average area under the curve for the receiver operating curve, and then used the best model to fit to then the whole sample. So here are results in our conditional inference tree that came out from this analysis. Our average area under the curve for our best conditional inference tree was 0.54. This is slightly better than random chance, which is 0.5. And then this is what happens when we apply this to the whole sample. As you can see here, demographic variables were not selected as predictors, but we do see some of the emotion regulation subscales as well as some of the sleep subscales, and I'll go into those in detail in a moment. I just want to orient you first to the structure of this tree. So each of the little boxes represents a node. We have a primary node or parent node at the top, which is our strategies emotion regulation subscale. And then we have other split nodes that come along the way that end in final or terminal nodes, 5 of which we see at the bottom there. And each of these branches is split again by those permutation tests where we found a significant value upon which to split. And this is all done by the model itself. And now at the very bottom, you can see here the buckets at the end are terminal nodes. The gray values, the more gray you see, the gray indicates the proportion of individuals with anxiety disorders in that terminal node. And then the white indicates the proportion of individuals who are healthy controls in that terminal node. So I want to start by going down the right side of this tree. And the right side of this tree is indicative of individuals with poorer emotion regulation strategies. And that was determined to be a cut point by the model of a score of greater than 12 on the strategies subscale of the DERS, which is a subscale that ranges from 5 to 25. And overall, if we look down this full branch that ends in 2 terminal nodes, those with poorer emotion regulation strategies make up 94% of those had a current anxiety diagnosis. So mostly the gray you see here. Only 14 of these 233 participants who had poor emotion regulation strategies were healthy controls. And then here, if we look down this full right side of the model, these are individuals that have both poor emotion regulation strategies and less ability to accept negative or uncomfortable emotions. Here, the model identified a cut point on the non-acceptance subscale of greater than 13. The subscale ranges from 6 to 30. And if individuals had both poor emotion regulation strategies and inability to accept negative emotions, it was almost guaranteed that they were in the anxiety disorder group. 99.3% of individuals had anxiety disorders. Only 1% was a healthy control in this terminal node. If we go down this branch, this represents individuals with poor emotion regulation strategies who have a better ability to accept or tolerate negative emotions. Here we see still pretty a high percentage of individuals have a current anxiety diagnosis at 84.5%. So really what we're seeing on this right side of our tree is that emotion regulation subscales are very highly related to, and dysregulation in these subscales are very highly related to anxiety disorder diagnosis. Now let's make our way down the left side of the tree. And this represents individuals who had better strategies to regulate their emotions, here represented by a score of less than or equal to 12 on the strategy subscale. And then you can see that this branch is split into 3 terminal nodes by 2 sleep-related subscales. First is sleep quality, and then daytime dysfunction due to poor sleep. And what is really notable here is that any sleep disturbance on these subscales, so anything greater than 0, and remember higher scores are worse functioning, was more associated with individuals who had an anxiety diagnosis, even for individuals with better emotion regulation strategies. So this terminal node here is represented as 59.5% have anxiety disorders. Now, if we go down the full left side of this model, we see here individuals who had good strategies to regulate emotions and overall good sleep quality. And this was almost wholly occupied by healthy controls at 88.2% healthy controls. So in general, what we see by this left side of the tree is that those with better emotion regulation strategies in these 3 terminal nodes were mostly representative of healthy controls, 69%, so 78 of these 113 individuals with better emotion regulation strategies. So what can we take away from this? First, a little shout out to using these machine learning models, particularly a conditional inference tree, which can provide an easily interpretable set of heuristics that can be used in clinical or research settings, of course, when replicated in other samples. And in particular, they can be used to predict certain things. In our case here, anxiety disorder diagnosis, based on certain predictors, in our case, disrupted facets of emotion regulation and sleep. And now what we found from our particular conditional inference tree is aligned with our hypotheses that 2 specific subscales related to emotion regulation appeared to be the most valid factors associated with anxiety disorder diagnosis. And the overarching factor, our parent node of this tree, was poor strategies to manage negative emotions, and then also further split by less ability to accept the presence of negative emotions. Then we found that sleep was a secondary factor of importance, particularly for those who had better emotion regulation abilities. And this aligns with meta-analyses that sleep quality is poorer in those with anxiety disorders. So we did find an importance here of sleep quality, which we had predicted as part of our hypotheses. We did not see sleep duration come out, but we did see daytime dysfunction also come out. And again, there's probably a bidirectional relationship here, or really a multi-directional dynamic relationship among all these 3 factors, whereby chronic sleep disturbance may increase likelihood of anxiety disorder onset, presence of anxiety disorder may impact sleep, and also leave people more vulnerable. When people aren't sleeping, they're more vulnerable to emotion dysregulation as well. So a few limitations and potential future directions. As I noted, these questionnaires were completed at a single time point, representing cross-sectional data. So of course, we would want to replicate these findings and particularly replicate them in longitudinal data sets where we can identify the directionality of the effects and some causality. And this will be particularly helpful to really understand the dynamic interplay among sleep disturbance, emotion regulation, and anxiety, and to identify early intervention targets as well. Our anxiety population consisted just of individuals with primary generalized anxiety disorder and social anxiety disorder. It'll be important to replicate these findings across larger samples of larger amounts of different types of anxiety disorders, as well as a fuller range of conditions, including things like depressive disorders and post-traumatic stress disorder. For our study, we didn't have available information about comorbid sleep disorders, which of course can impact sleep, like obstructive sleep apnea. Though our sample size was about 350 people, it's still considered a pretty small sample size for implementation of these machine learning techniques. So ideally, this would be replicated in larger sample sizes across multiple data sets. And this might be representative of our AUC, which was particularly close to chance. We also relied on participant self-report for sleep disturbance and emotion regulation difficulties. It'll be interesting to see if these results could hold when using other types of assessments of these constructs. For example, behavioral assessment of emotion regulation, and objective assessment of sleep quality using something like polysomnography. Nevertheless, there are some clinical implications, and particularly these clinical implications will become more into focus when these factors are investigated longitudinally to understand the developmental course and where the early intervention targets are located, as well as when these things are replicated across broader samples. And then we can potentially implement some of these proposed strategies of known evidence-based interventions or even develop new interventions to target the facets of interest. But when we're thinking about our emotion regulation challenges that we identified, first we identified strategies to manage negative emotions that were impacted. And one such strategy is cognitive reappraisal, which is the ability to reinterpret negative thoughts related to anxiety to be more adaptive. And this we know is a core change mechanism of cognitive behavior therapy. So this can be something that can target that strategy's emotion regulation bit. In terms of acceptance-based models, they suggest the role of negative response to an avoidance of uncomfortable or threatening emotions. This is aligned with our finding of the non-acceptance facet being important in predicting anxiety diagnosis. This can be targeted with therapies such as acceptance and commitment therapy or mindfulness-based therapies like mindfulness-based stress reduction or mindfulness-based cognitive therapy. In sleep, to target sleep disturbance, cognitive behavior therapy for insomnia, or CBTI, is a well-established brief therapy targeting both short-term and long-term sleep problems and has demonstrated efficacy for improving sleep quality, which was one of those facets that we found disturbed for those with anxiety disorders. So I want to end today with another thank you to ADAA and the Donald F. Klein Early Career Investigator Award. As I mentioned, I was able to attend the 2024 conference in Boston, Massachusetts, so got to go back to where I completed my graduate school time. And I also got my picture on this nifty poster that was displayed throughout the conference, which is now on display in my living room of my apartment. And really, since my first ADAA conference in 2010, I've considered it one of my conference homes, and I've really enjoyed attending this conference to see the broad spectrum of research represented, from basic science to clinical intervention studies. I also want to give a shout out to ADAA, which does a really great job of fostering the growth of young people and early investigators, from students to postdoctoral fellows to early career researchers. One such way in which they do this is through the Early Career Professionals and Students Special Interest Group, as well as the outstanding program, the Elise Muskin Career Development Leadership Program that I mentioned I participated in 2018 as a postdoctoral fellow. Through this program, I got to meet other anxiety and depression researchers and peers and colleagues. I was paired with an excellent mentor, Jasper Smits, in my area of exercise-related research, and participated in groups led by other fantastic mentors as well. So I highly recommend ADAA and all that it does to foster the growth of early career professionals. And finally, carrying on the tradition from previous 2022 Klein awardee Dr. Sage Hahn, I want to conclude with thanking you for your attention and a special shout out to my fur baby, Sadie Noodle, who you see here. She is both the cuddliest research assistant, but also likes to insert some random letters into my papers when she trots along the keyboard. And then here you can see I've included my email for any follow-up questions or comments that you might have. Please do feel free to reach out to me. I very much enjoy speaking about my work. Thank you so much, and I appreciate your attention.
The Anxiety and Depression Association of America works to prevent, treat, and cure anxiety disorders and depression through the alignment of science, treatment, and education. If you're not yet a member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy the webinars and blogs, posts from professionals, ADAA member self-help books and publications, subscription access to Insights, which is our professional newsletter. We ask you to visit adaa.org to learn more. Thank you for joining us. We'll see you next time.